Recording in progress.
Yeah. All right. So I think this is a really important topic, and I'm really refreshing the upper levels and really shooting at the PGY1s and the students in the room. So I hope that this really absorbs into you. So I want to talk today about this overlap between presentations of hypertensive emergency or malignant hypertension and acute ischemic stroke. And I really want to look at strategies and the pitfalls of when we don't follow a safe strategy when we're pondering this differential diagnosis. What sorts of things can we use to tell the difference between these two very radically different diseases? And then how would we treat them different? So let's look at a case. So our case is a 65-year-old Caucasian male. He comes in with blurred vision, weakness, feels poorly. He has all the substrates to be a vasculopath, and from those stents in his RCA, I'm going to say he is a vasculopath. He continues to smoke heavily to continue to be a vasculopath, and he's on pretty appropriate therapies for his disease process and for his vascular disease. And he comes from a long and distinguished line of vasculopaths, so vasculopathy. So on presentation, you can see he's got some pretty impressive blood pressure, but otherwise his vital signs are pretty meh. And this is his physical exam. So you can see that his cranial nerves don't seem to be working appropriately. His speech is a bit slurred, but I've never met the guy before. Maybe that's a thing. Otherwise, he doesn't really seem to have really major focal motor findings. He does have a pretty decent left carotid bruit. He's got an S4 gallop and a regular rate and rhythm. Lungs are clear. He's obese, but there's no organomegaly. So this is our guy, right? So I don't know if that eye is always like that. I don't know if his speech is always like that. Maybe he's been like that for 42 years. Maybe it's just started this morning. I don't really know. So differential diagnosis and hypothesis. Who wants to help me out with this one? Dr. Johnson?
So I think at the top of the differential should be stroke.
It should be a stroke, right?
On that, blood pressure 205 systolic. Also the lecture hypertensive.
Sure.
Beyond that, is he potentially having some other finding as far as like a heart attack?
Oh, hope not. I guess I should have put an EKG in. So I don't know that there's any way for me to really tell between those two states. There's so much overlap between how those two disease states that you brought up can present that I don't really know. And when you look at the differential diagnosis between ischemic stroke and malignant hypertension, they share a lot of the same differential. And in fact, acute CVA is on the differential diagnosis for malignant hypertension. So there's a lot of different things that can present and fall under this differential diagnosis. So, and this is the major point of this entire topic, which is, well, what's the pitfall when I misdiagnose these two things? So what's the downside when I guess and I guess wrong? Well, let's talk about it. So are you guys familiar with the Rankin scale? So a Rankin scale, if you're a neurologist, is pretty useful because what it does, or the modified Rankin scale, describes the level of a deficit based upon a stroke, okay? So whereas 0 is no symptoms at all and 6 is the symptom of being dead, and then there's a gradient across that. And I kind of think of 3 as the dividing line. Once you go above a modified Rankin of 3, you're probably going to be severely impacted in your overall functioning. You're probably not going to get to be an autonomous human being ever again, right? So we don't want that Rankin 3, 4, 5, right? So here's what we need to avoid. So this is a 2003 study out of the Annals of Emergency Medicine looking at the association between the course of blood pressures over the first 24 hours of an ischemic stroke and what kind of recovery did they have. And what they found was that for people whose diastolic blood pressures were decreased by more than 25% from time of admission, their outcomes were really poor as based on a Rankin scale. And so look at this study. So as you can see, we said a Rankin 3 to 5 is bad. This is you going to a nursing home, never to be seen again. 0 to 2 is maybe you get to see the golf course and play with your grandkids. Look what happens when you're really aggressive with lowering diastolic blood pressures. This Rankin scale of 3 to 5, we've doubled the amount of people we shoved them into a nursing home when we aggressively treated those blood pressures. It was far better to be super neglectful, man. Just don't even check the goddamn blood pressure. Your patients would have been better off by a factor of 2, right? And so this is one of the first times when we're looking at this where we're starting to realize, wait a minute, there's major consequences to getting it wrong, right? And I think that that's a really important point. A lot of times we get these calls from our ER or outside, and they want to give you a diagnosis. They're going to say, I want to admit this patient for hypertensive emergency. And they have committed to that diagnosis. And sometimes I think that we have committed a little too early. And the reason that I think that this is an important topic is because of this concept of the ischemic penumbra. When we have an acute stroke, the bullseye is all dead tissue. I cannot fix that for you without stem cell therapy. You're just locked in, right? But as we move out of the zones of the bullseye, we have ever decreasing levels of ischemia. There's less and less and less jeopardized tissue that we can lose. That reactive hypertension helps to limit that area of ischemia. We want to keep that ischemic penumbra as tight and small as we absolutely can, and we need the blood pressure to be able to do that. So that brings us to major goal number 2. How the heck am I supposed to tell the difference between malignant hypertension and an ischemic stroke? Who doesn't like dog pictures? So when we probably should go over some definitions. So, and you guys know these things. So hypertensive emergency is high blood pressures that cause end organ damage. And sometimes they put in the blood pressures, and sometimes they don't. Do you guys use the blood pressure cutoffs like 185 over 105 plus the end organ damage? Is that the way you guys still follow with that? Yes. Me too. That's the way I was taught. Sometimes I see the definition where they're like, well, you don't have to be at 185 over 100 to have, if you're always at, if you're a small Asian woman and your typical blood pressure is 95 over 30, and now you're at 160, could that person have malignant hypertension? Yeah, I suppose they probably could. But as a general rule, we kind of think about those 180 over 105 cutoffs, right? So I'll do this one for you. So with blood pressures, when it comes to malignant hypertension, anything over 180 over 120 kind of meets our cutoff. The average blood pressures on these patients when they hit the ER is about 204 over 115. Whereas most people who have ischemic stroke and reactive hypertension, they may be high, but most of the time they're not that high. They can be. I won't say you can't see it because you will see it. But most of the time, I'm seeing the 170s, 180s. I see more of that. So they're really stellarly high blood pressures, short of people who have like a hemorrhagic stroke. I just think you're more likely to see that in the hypertensive emergency patient. And again, don't hold it to me. You're all going to see patients where you're like, I'm calling Dr. Mcnab. This patient had blood pressure in the 200s and they had a stroke. You will see those. As a general rule, the higher the number goes, the more likely it will turn out to be a malignant issue. All right, what about fundoscopic exam? What am I going to see as the difference between somebody with an ischemic stroke and malignant hypertension? Would you guys expect to see eye ground changes in somebody with an ischemic stroke because of the ischemic stroke? Not necessarily. It might be a very normal exam. What might I see with malignant hypertension? Retinal hemorrhages, right? Yeah. Tortuous blood vessels. Maybe they might have a little papilledema, right? So yeah, with ischemic strokes, most of the time, these patients are going to have a fairly boring looking exam and definitely are not going to manifest evidence of papilledema. They shouldn't anyway, which of course, papilledema for a plunker like me means you start to see this lack of nice, sharp, crisp disc borders, right? So it gets all real blurry because the edema kind of shoves everything out towards you, starts to obscure the borders. And this is a no-brainer. That is because of the hypertension, right? Okay. Well, what about the CNS findings? How would they potentially be different between malignant hypertension and a stroke? Yeah, I would like to think that that would be the case as a general rule, especially for like real large vessel stuff, right? You know, it's so nice when you have lateralizing findings. That helps me so much, you know. I can't tell you how many times I've seen these patients who've had small frontal lobe strokes where they just act weird, and you know, their physical neurological exam doesn't look, it ain't focal, but then you got these family members who are like, that is not how my mother acts. Something is wrong. And eventually you end up MRIing them. And sure as hell, they've had a little frontal lobe stroke. And you're like, okay. But you know, it's so nice that, you know, these people will sometimes give you a nice lateralizing motor deficit or sensory deficit. And that really helps out. They've lost something that they used to have. Whereas with people with malignant hypertension, it tends to be more systemic. They're stuporous, they're having seizures, you know, they're agitated, that sort of thing. They have altered mental status that you would describe as encephalopathic, whether that's metabolic or toxic or what have you. Lateralizing findings would be uncommon in this case. But again, you know, when you're seeing these patients for the first time, you know, I think everybody in this room has at least twice started a conversation with me like, well, this was a very poor historian. You know, they always qualify. Here's why I don't have all the information. Patient's a poor historian. But you don't know these people, man. You have no idea what their baseline neurological function looks like. So that lateralizing weakness that they come in with, is that chronic? Is it brand new? I don't really know, man. Hard to say. When you look at imaging, I think that this can start to help you out. So on MRI, if you're thinking about malignant hypertension, what you're looking for is these little hypertensive arteriopathies, these tiny little bleeds. And so the best way to see these is on T2 imaging. You see these little flow voids, the little black, little buckshot looking things. This is what a hypertensive bleed looks like. These are little micro bleeds into the deep tissues of the brain, typically down in the basal ganglia region, that sort of thing, kind of as demonstrated in this cartoon. So all this crazy little buckshot on a T2 imaging, that's really suggestive of malignant hypertension, right? So that is what we would expect to see. And this part of it is part of why they're acting so weird and crazy. I mean, you're really harming the parenchyma of the brain. But this is what a stroke looks like. So when we said T2 imaging is what we should be looking at to see changes of a hypertensive bleed. Diffusion weighted imaging is what we need to be looking at if we want to see acute strokes. And obviously, from a non-radiologist perspective, these look remarkably different, don't they? Yeah, absolutely. This is a large monovascular territory. You know, of course, you can have an embolic stroke, but it's going to be this, but mixed through a few different territories. So MRI really helps out quite a bit. Cardiology finding. So it can be a lot of overlap. You know, you can have active ACS as part of your stroke. In fact, people who have strokes are at higher risk to have a myocardial infarction and vice versa, right? Whereas people with malignant hypertension, their end organ effect could be they just can't tolerate trying to push against that kind of afterload, and now they're infarcting, right? So there can be a lot of overlaps in the cardiologic findings between these two things, except, pulmonary edema is probably not a stroke, right? Those people that get that reactive hypertension, I've never seen somebody that decompensates. Well, never. I don't know that I can actively remember anybody who had a stroke, got reactive hypertension, and then because of poor pump, they threw themselves into pulmonary edema. I'm not saying it's never happened, but nothing sticks out in my mind. That would be pretty rare consortium findings. So, but it's not uncommon for somebody with malignant hypertension present in decompensated heart failure just because the afterload is so tremendous that they just can't do the job. Okay. Renal findings between a stroke and malignant hypertension. It's good to have an AKI with malignant hypertension. Yeah, so you would think that they may have some findings. They may not have bland urine. You might be tearing up the kidneys quite a bit. Could have an AKI. With a stroke, it may not even be relevant. They may have completely normal function, or they're old. They could have a CKD, but stable, that sort of thing. An active renal problem is not going to be your issue with somebody who presents with an ischemic stroke, right? So here's my problem, and the problem I want you guys to be aware of is that the presentation of malignant hypertension and ischemic stroke can have a lot of overlap, and making the wrong diagnosis and the wrong treatment plan can turn out to have disastrous consequences when you do the wrong thing. So in my mind, the right strategy is to do what Dr. Johnson said, which is always rule out the stroke first. It doesn't take much to get a fast MRI done and just say there is or is not a stroke here, right? I think it's a good use of the resource, and it's a good use of the time before you commit to a diagnosis of malignant hypertension because of this. How we see the differences in treatment between these two things, right? So what are our goals with malignant hypertension? Greater than 185 over 100 something or other. So in the first hour, if you've got malignant hypertension, I should reduce your overall blood pressure by how much? Depends on the literature, right? 25%, yes. No more than 25%, right? You can still see that graph in your, from the previous Annals of Emergency Medicine, looking at that negative 25% reduction in diastolic blood pressures, and looking at how much Rankin score, oh man, doubled the amount of severe Rankin scores, right? So when you think about malignant hypertension, I think this says it all, man. So, this is a normal arteriole. It has the ability to open and close at the end organ level to control blood pressure. Oh yeah, this guy, it's definitely fully functional, right? So all this onion skinning that you guys learned about in medical school, because of chronic hypertension, these arterioles' ability to control autoregulation is probably shot to hell. And so the thing that holds chronic hypertensive patients in perfusion is systemic pressures, right? And so when you bottom out these people's blood pressures with aggressive treatment, they're not going to be able to compensate and clean up the mess for you. And that can get you into real trouble with these patients. So our goals for malignant hypertension are to try to reduce, and the literature's all over the place, no more than 25%, it depends on what you read, somewhere between 10 and 25% in the first hour. That's a pretty reasonable thing to do. And then over the next day, another 10 or 15%. So we're really just trying to get their blood pressures less than this 180 over 120 in the first hour. And then this says over the next 24 hours to get it down. Honestly, once I get you to stop like exploding your brain, after that, I make a dose adjustment to your chronic blood pressure regime, and I give you 4 to 6 weeks to normalize your blood pressures, because it can take quite a while for you to be able to adapt to the new medication, right? Anderson, how long does it take for you to get to steady state when I adjust your blood pressure medicines?
4 to 6 weeks.
4 to 6 weeks, man, 4 to 6 weeks. So don't change it the next day and the next day and the next day, and don't let the nephrologist change it 5 times. Is that what you're saying? I'm going to talk to Dr. Hamlin about that. All right. So what about ischemic stroke? What are our blood pressure goals? 220 over 110? Yeah, that's a crazy high number, isn't it? Yeah, absolutely. So if you're not a TPA candidate, I don't want, as long as it's below 220 over 110, I'm not going to treat it. So if you're at malignant hypertensive levels and you're having a stroke, I ain't going to touch you. I am not going to touch that unless I need a TPA, right? So, and that's a hard thing. You see that, you want to do something with it. The nursing staff wants to do something with that. We all want to do something with that. We know it's bad, but there's that ischemic penumbra. And it's just sitting there and it's asking the question, well, what do you want this patient's modified Rankin score to be? Because you've got a lot of power over that situation. Nursing homes suck, guys. It really does. And even if you are going to TPA the patient, you only need to be below 185 over 110, right? That's still at the top end of the malignant hypertension treatment recommendations, right? So, these are still pretty high that we leave these patients, even if you're going to TPA them. So part of the problem with aggressive therapy is this guy right here. So coming off the carotid, you can see that this portion of the internal carotid goes down to kind of this little pip squeaker of a thing when it really should look more like that with treatment. And when you realize that you're having to push against this gradient, I don't know what the blood pressure gradient must be in something that small, but I always kind of imagine the difference between trying to suck a giant shake through like one of those humongous McDonald's straw versus the little coffee stirring sippy straw, trying to get enough pressure to go across that. Well, if this is what you're pushing against, and this is the reason why you had the stroke in the first place, you may need a hell of a lot of blood pressure to be able to get anything through there. And I don't know what your circle of Willis looks like. I don't know. I'd like to think we all got a pretty good circle of Willis, but I meet people who have all kinds of deficits all the time. And so intracranial stenosis can be a really important factor on how people can tolerate big changes in their blood pressure. And so this is why I always kind of harp at the residents about why CT angiograms of the head and neck are so important. Because if you've got wide open blood vessels, if you're this guy, then after you've gone 24, 48 hours and you're neurologically stable, then you can put those people back on their blood pressure medicines and nothing bad's going to happen to them. They're fine. But if you're this guy, then you need like a week to 2 weeks of being terribly afraid and reluctant to start these people's antihypertensives or to make aggressive changes before you restart them. Because otherwise, that modified Rankin scale is yours to own. You're like, I don't like, I think a 5 sounds good for you, right? That's a terrible idea. So in conclusion, my constant worry is that I'm going to make a mistake. I'm going to think malignant hypertension when I should have diagnosed a stroke. And that allows me the ability to really permanently harm somebody. And I won't even kill them. That's the thing. If I just murdered you, well, you're dead. You go to heaven, whatever. I think, so in this analogy, dead is worse than nursing home. Obviously, I have some implicit biases about nursing homes. So we don't want that to be the thing. So always, our strategy needs to be rule out the ischemic stroke first before pulling the trigger on treating somebody for hypertensive emergency, because we don't want to worsen that ischemic penumbra. Get the MRI first and then be brave. But if you guys constantly follow a strategy where you put yourself at risk of being screwed or screwing the patient when you're wrong, at some point you're going to be wrong. And then the patient pays, right? And they pay in neurons, so, and nursing home bills too. So I think that this is a better strategy. Does this make sense to you guys? I really, really want you to adopt this. This is the safest way for you to take the best of care of patients who can really have a tremendously different outcome based upon how you play the game. Then after that, once you've made an appropriate diagnosis, really make sure that you're following the guidelines for treatment parameters as tightly as you can. Because again, I'm always so worried about autoregulation issues. The people that are most likely to come to the hospital with malignant hypertension as their diagnosis are people that are chronically hypertensive and chronically poorly controlled. And then they screw something up, like they go 2 days without taking their blood pressure medicine. So they're always kind of super high, right? And then they spike higher than that. That person that I just described, that's the person who's least likely to be able to auto-regulate safely. When they're that high, that long, thinking about those arterials that are all screwed up like we just looked at, that's what they've got. So systemic blood pressure to them is tremendously important. If you're heavy-handed, you're definitely going to murder some neurons. All right. What do you think? Are you in on this strategy or do you want to fist fight about it? No? Any questions about it? No? You're all fans. Dr. Miller, she's like, no arguments here. All right. Well, very cool. Any questions, concerns, or disbeliefs?
I have a question.
Please.
What do you usually use as antihypertensive to lower the medication?
That is a great question. So the question for the Zoom world is, well, what do we use to treat? All right. I mean, I'm guessing you're talking about malignant hypertension.
Yes.
Yeah. So around these here parts, cardine drip seems to be pretty popular. I don't really see any reason to change that. I think the ER has a real tendency or they favor it. And most of the time I'm getting the patients from them. So they come to me on a cardine drip. So the thing I like about cardine is it's very short acting. You can titrate it in real time and you can get rid of it when you don't want it. So what I'm typically doing with these patients after I rule out the ischemic stroke, right? After, that's the whole point, is I will reinitiate them on all of their home medications on top of the cardine drip, right? So, one thing that happens, like with the PGY1s, or frequently they'll admit the patient on the cardine drip, they leave them on the cardine drip, and then in their note they say, wean off the cardine drip. Well, how do you wean off of a cardine drip? Well, you wean off of it by restarting your home medications and then trying to decide, what do I need to do with your home medication regime? And so that involves a conversation with the patient. So if you're on a chronic blood pressure regime and it typically keeps your blood pressures well controlled, but then you got nauseated and stopped taking your medicines for 2 or 3 days, it sounds like this regime works for you. You were just had a non-compliant issue for one reason or another. I'm not going to make any changes. I'm just going to start your antihypertensives, get them back into your system, and then I'm going to wean off the cardine back to your baseline. If in discussion it sounds like you're always poorly managed, then I'm going to restart your antihypertensive regime and I'm going to make an adjustment to it. So I may bump you may be on lisinopril and middle dose Coreg and a diuretic. So I'm gonna make some changes there. This Coreg at 12.5 twice a day, I'm gonna bump that to 25 twice a day. That's my change. And now I'm gonna lower down on the cardine drip, wean you off of that, and then send you away. Because really, I don't know whether that change to your blood pressure is going to be effective, too much or too little, for a month to month and a half. But I do know I don't want hypotension either, right? So that's the typical strategy for me on how to manage them acutely. I'm doing that with the cardine drip primarily, and then getting them off of it and then readjusting from there. Does that make sense? Do you guys?
End up doing when you get them on a cardiac group and they've already dropped from like 220 to 150.
Oh gosh, it comes off. Yeah.
You go ahead and start their home medicines at that time.
No.
Yeah.
No. If they've crashed their blood pressures, then I'm going to stop all the antihypertensives and clear the pharmacological milieu, and then let them kind of float back up. If they get back into an emergency range, then I may start the game again and be less heavy-handed. If they don't float back up, then I'm probably just going to sit there and stare at them and then start to make some decisions based on the blood pressures they give me. If their blood pressures are 130s over 70s for 24 hours, maybe they need to go talk to their doctor. Maybe they don't need blood pressure medicine. That would be my thought, but yeah, I'm really afraid. You're never gonna add blood pressure back to these people. You're like, no, put them on a pressor. You know, it's not like that. It's not like hyponatremia therapy or that sort of thing. But you definitely don't want to force them to stay that low once they've gotten there. So no, I just stop everything and then I hold my breath and wait. So that'd be my thought. And that's the beautiful thing about the cardine is it's so short acting that theoretically that should not be stopping the autonomic nervous system from doing what it wants to do to kind of right size its response to whatever situation they're in, right?
And I think I found that the education in the ER, they don't have that, so they're tight too. So they're
Yeah.
20.
Yeah, I think that's there's always an educational opportunity and, and that might be a useful topic for a NED talk, actually. I think that might be a really good one. I do typically, if I'm doing something that that needs fine work, I frequently will tell the nurse what my goal is. Here's what I want you to get it to and why, right? Because I find once I've kind of educated you on why something has to be a certain way, then that nurse is never going to screw that up ever again. A lot of times they just don't have the pathophysiology and the pharmacology that we do to really understand the situation. So they, I think if we went around and did a once around the hospital asking, well, what's an ischemic penumbra to the nursing staff, I think we would get some really interestingly skewed results towards the negative. I don't think they probably do know. Or if you asked them, if you knew, you just asked them, well, why is it important to keep a stroke patient's blood pressure super high? Some of them would probably know that you need to, but if you got to the level, yeah, but why do you need to? I would be surprised if 25% of them actually could tell you why, right? So so I always think that it's worthy of education. And I know as house officers, how many times have you guys been called on stroke patients in the middle of the night where the nurse wants you to interact with the blood pressure? Is that a common thing for you guys? It's a super common thing, it's a very cautionary tale for the PGY1s and the medical students. The nurses are going to try to talk you into doing the wrong thing because they don't know any better. And you can either just tell them nope and yell at them, or you can help educate them into understanding why. Because they're going to see a lot of stroke patients, right? So the quicker they get that knowledge, the better off they're going to be in helping you take care of your patients. So that's what I do with it anyway. Any other good questions? All right. So please help me, help you, help the patients. Rule out the stroke first. After that, follow these guidelines. And we're all going to be a lot happier because of it. So take that and run with it. All righty, guys. Well, I guess we need to get over to the that.
It seemed like it's a big auditorium.
That's right, man.